Okay, I'm being nice to you guys today. I am recording it on Zoom, but I'm not making you watch me up here while I'm talking. So if you notice, I'm just like stuck in one place. That's kind of why, since I am on the trying to record it for a couple people who are sick right now. So, like I said, since this class is about assessment, a lot of the things that, assessment is, when you do an assessment, obviously, you're going to have to document what you find, right? So this fits in because it may not go perhaps in a medical chart, as it says at the top of the page here, but it's going to go in the patient's file. It's going to go, somewhere. It's part of the professionalism that we use, is being able to do our documentation properly. So there's just some things on here that I made some notes prior to coming in here, and we're just going to talk about. It's just an overall overview of how we should write in a chart, what we should do, what we shouldn't do. Again, no big. Oh, by the way, did everybody get the email thing that the announcement that I sent out today? Hopefully a few of you guys can make it. I'm on the committee, and they asked us to ask our students to come, and I was like, well, they're sure not going to come if I don't offer them something. So that's why I threw the little incentive on there. It's not huge, but it could help in the long run if you have. And it's supposedly going to be, kind of an interactive, good, hopefully a good topic that she's talking on and all that good stuff. So let's see. Something that we haven't talked a ton about in the TR classes. Now we have talked about documentation, and we've talked about that in terms of writing goals and objectives and evaluation, but what that's called a lot of times is progress notes, simply. So in some cases, like when I was at NMRC, we had so many large group activities when I was there, and to be honest with you, there were a lot of times, because of staffing, because of whatever was going on, what we were doing was not, sometimes it was more recreational, less therapeutic recreational. We weren't, we just were kind of herding cats and doing something to keep everybody busy, That being said, progress notes would have been very difficult to go back and write progress notes for the 50 people that we just did an activity with. How are you going to even remember what everybody did? But in many cases, like say the treatment center, Oxford Treatment Center, most recreation positions you have to do progress notes, which is basically just, this is how today's class went. This is how Tom did today during the activity. This is what I saw, and it's subjective, and it's not meant to be opinion based, if you know what I'm saying. Like, if he was sad and withdrawn, then he was sad and withdrawn. It's not, I believe he was sad today. You know what I mean? It needs to be definitive, and it needs to be objective to exactly what's happening. It's not subjective where you're throwing in your own thought processes. It says here, it's the second paragraph on the first page. There's many reasons for writing progress notes besides documenting the results on an assessment. These include recording the patient's ongoing status, communicating with other members of the treatment team, because sometimes you're busy, right? But somebody may need to know what's going on with the patient. So if you have left progress notes, if you have done documentation, then they can find out what happened earlier in the day while they were with you. Were they acting this way earlier? Let me check Michaela's notes and see if this was happening earlier in the day. So that's part of it. It also provides justification for billing. Remember that. It goes along with that, what we said. If you don't write it down, if you don't document it, it didn't happen. And many times, state and federal law comes into play, and it requires documentation to be there. So remember that. Now go down, skip skip a paragraph, and then we go to the recreational therapist's effectiveness is increased when he or she is viewed as an important member of the treatment team. Accurate, concise, useful documentation is vital in creating this perception because the way the treatment team, the facility's administration, and accrediting agencies view the recreational therapist is influenced by how and what they write in the medical chart. So that, in a nutshell, is why this is important. You know, it's going to change how you're viewed if you're being effective with what you're writing and if you're doing it in an intelligent, proper manner. So skip over to basic rules when writing in a chart. Number one, you need to record accurate, factual events that you can personally vouch for because you observed it, you smelled it, you heard it, or you touched it. That's what I'm saying. It's factual. It is not an opinion. It is something that did occur. Something that if someone else was making the same note and they were present, it should be very similar because it's not any question of whether or not it occurred. Number two, you need to write in a chart in a timely manner following basic documentation guidelines. Why should we keep it in a timely manner?
You're there for the client, not to write down everything the client does necessarily right then and there.
Right. Usually it happens after the event, obviously, because you don't want to be trying to facilitate an activity and sitting there writing notes on everybody. Now, might you have a tally sheet or something where you can check a few things as it going on, especially for specific ones? If you have an issue, yes, that'd be okay. But you're not sitting there just writing and not paying attention to what's going on. Think about like say a crime is committed. Are you going to get a more accurate description of the assailant immediately after or 2 weeks after? Immediately. So that's kind of where timely comes in. You need to, and most places have this in their, you know, the way everything is set up. There's time set into the day after activities to do progress notes. And that's just part of it. So you, something important here. Do not document about patient actions before they happen. Obviously, that's a no-no. Now, would it be sometimes tempting when you know you've got a butt ton of paperwork that you're going to have to do, and you already saw this client earlier in the day, and you know that he's excited about it and he's coming, and theoretically you could almost write their progress note. You know, Tom came to the event, he really enjoyed what we did, he was very active. Like, you know what he's going to do. But you can't write it in advance because then he may not show up. I mean, it's just not ethically okay. But it's put there, this is in here for a reason because it can be almost tempting if you're trying to save time, and so don't ever do that. Also, backdating notes, adding a note at a later date, writing between lines or squeezing in words shouldn't be done. It's kind of like tampering with evidence, you know, because what we're doing with documentation is creating evidence of what has been going on, you know. So that's kind of a strong way to put it, but it's really, in theory, what you're doing. Number 3 on the next page. Therapists should make error corrections by drawing a single line through inaccurate material and then date and initial it to show that you are the one that made the correction. By the single line, you can still see what was there. It's not like you were scribbling and trying to hide something. Just kind of important. Never obliterate material on the record by scratching it out, erasing it, or using whiteout. Whiteout is my friend. I love whiteout. I got 2 of those little roller things of whiteout today out of our closet because I go through that much of it in my office when I'm just doing my everyday paperwork in there. Number 4, therapist needs to keep in mind that the chart is a means of communication for the various medical personnel involved in the patient's care and a repository for objective accounting for the progress or lack of in resolving the patient's medical problems. Mental, medical, emotional, whatever they're dealing with when we're talking about recreation therapy. It is a way of communicating. Like I said, it doesn't always make sense for us to call a meeting to discuss a client. But someone can come and check other people's progress notes, and that's why they're generally put in a place where you can get to them and you can review notes. What you're writing for the team is not confidential. You're not dealing with confidentiality because you're all working with these patients and you all know not to go home and talk about it necessarily, but you can share your documentation at work. So, skip a sentence there. Careless, unsubstantiated statements. For example, patient's mother appeared schizophrenic. May haunt the therapist and his or her facility long after the patient's medical problems are resolved. You may think that, but should you put it in the chart? No. Believe me, I've dealt with families for a lot of years, like when we would have our yearly IPP meeting and the family members would come in and we would go over what they're going to do for the next year with the patients, with our clients, and with their family members. And let me tell you, some of the family members, I thought to myself, whoa, they need to be here more than their child does. I didn't go down and write that in a chart. Just saying, you have to keep it professional and not put things because once you write it down, it's there. You know, even if you come back and put a single line through it and a date, it's still there. So, number 5, document frequently enough to demonstrate continuity of patient care. Number 6, keep documentation concise and specific, but not so brief that you're leaving out important facts related to the patient's condition or treatment. So try to stay away from super long narratives. You know, you're not writing a book for everybody. Number 1, it's not necessary. Number 2, do you think, what's that going to do for your time management? Do you have time to write a book for everything that everybody does? No. You'll find ways to keep them concise, to the point, yet cover everything. It becomes easier through time, just like providing an activity. You know, just like leading an activity becomes easier in second-hand nature once you've done it for a little while. 7, therapist should sign and date every entry he or she makes. Therapist should also specify professional title there. So if you have the CTRS certification and you're doing documentation, you need to sign it, your name, CTRS, and put a date. It's just a good habit. That way, I always call them the watchdogs when the surveyors or the accrediting agencies that come in to check and see that you're doing what you're supposed to be doing. One of the first things they do a lot of times is just dig into your paperwork and documentation. They may not even go look at your facilities for a day and a half. They may look at your files and look at how you're documenting and what you're putting there. So another reason why we're having this discussion from this, and I wanted to go over it, it also lays the foundation, because as we go through this course, you're going to be writing out narratives for these different hypothetical case studies that we're going to be talking about. And I want you to think about, as you're writing these things out, some of these tips that are kind of in here, in the way that you are giving me the information. Number 8, therapist should not include documentation about the actions of other members of the treatment team in the patient's medical chart. Each professional is responsible for writing his or her own chart notes. Did I make a copy of mine on y'all? Does it have a note right there? On on mine, when I was writing that down, I actually put "stay in your lane" right there. Yeah, you mind your business and you let them deal with theirs. That's what that amounts to. You don't need to be writing about what Tammy from physical therapy did unless it directly pertains to something that you're doing in recreation therapy.
So let's say you're working with a group and two boys were known for stealing. One boy got in trouble, but the other boy is really the one initiating it. Peer pressuring this boy A to do whatever boy B tells him to do. How would that go about and really work? You know, boy A and his family, if he signs a confidentiality statement, he can read his own.
You would have to put on a boy who got in trouble who did not initiate it, you would put something along the line of, from what has been noted, Tom was I'm trying to think of the proper wording I want to use here. Was coerced into doing this by another client. You don't give the name. You don't put that. This happened after he had been, we talked to him after he told us that the other client told him it was a good idea. He did so. This is what we did about it. That would be kind of your documentation. You wouldn't give the name, but you would say, because you don't want to just put, Timmy stole something today during our class. Then it just looks bad. And it doesn't explain anything, and you haven't given the information. I mean, if it's factual that he had been peer pressured into do it, you need to put that. Then on the other person's chart, you need to say, Billy, at one point today during the activity, talked another one of our patients into stealing snacks for both of them. You don't give the name. You say what he did. It's still there. You're maintaining confidentiality. The other family doesn't see who it is. You do get into some tricky situations with confidentiality sometimes, like, say, perhaps if one client injures another one. Because what are mama and daddy going to be? Mad. They're going to want to know who did that to their baby, right? And here we are, trying to maintain confidentiality while still trying to appease the family. So you get that's where you kind of hand it to someone over your head and say, well, I want you to speak to my supervisor, and then they may send them to the next person up from them, and so situations like that, I handed those off when I could, honestly, because that's kind of what the protocol said at our facilities where I worked, But that's a situation where you do run into confidentiality. That's a good question. Number 9, use descriptive words when you're writing in a medical chart. It's important. Descriptive words tell a story succinctly. Like one word, a very descriptive word says a lot, right? We'll talk about some of those specific ones in a minute. Number 10. Okay, don't necessarily, this one I'm kind of in and out on. It says the therapist should avoid abbreviations. Now, here I am giving y'all an abbreviations test, right? Okay, now read the next part. The only abbreviations that are allowed in medical charts are those that are already approved by the facility where the therapist works. The medical records department should be able to provide the therapist with a set of approved abbreviations. So the ones that you're going to have a quiz on, and then another quiz that we marked on the sheet, those are ones that are very common. Those are ones that if you are reading an article, you may see abbreviated as well. These are just good ones to know because they're the common ones from this list that most facilities will be okay with these abbreviations. Now, case-to-case basis, So, let's go to 159, the next page. And it's talking about descriptive words to use when you're actually doing documentation. And I just had some that I marked because they were very, very descriptive to me. Like tense. Can you tell when someone is tense? It's all over them usually, you know. Rigid, that's actually a state of, that's kind of beyond tense. That's like you have to almost move the person, you know, that's descriptive. Relaxed, I like that one. Head down, is that subjective or objective? I mean, it's a fact, right? If they had their head down, it's pretty clear. Down to the movements, some of the ones that I've seen a lot. Self-stimulating, especially with people who have, you know, sensory issues, sensory needs. They do things like, you know, finger movements like this, or hand flapping, or even like buzzing and all sorts. I won't do that up here because then whoever walks by in the hall will think y'all's teacher is losing it. Hyper responsive kind of means like on edge. The smallest thing makes them just jump. Listless, dexterity. What is dexterity? If you have good dexterity, you have good... Anybody know?
Flexibility.
Close. It kind of fits in there. Like
Is it like movement of like fingers?
yeah, it's coordination basically. Your dexterity. Some days they may have better dexterity than others, especially if they're on certain medications, have been through some sort of trauma, things like that. Dexterity, yeah, fingers, it's funny you said that. When you're talking about dexterity, fingers are usually brought in because that's your fine motor skill area more than anything. You know, so finger dexterity is actually a common one that's used. Tremors, rocking, repetitive, eye-hand coordination fits in with dexterity. All of these are good descriptive words. These are just certain ones that I've used, that I've seen, that are common. Could be with multiple different groups. Helpful words to remember. Demonstrates is a good word. It's basically saying he shows that, it means the same as shows above it. Demonstrates is a little more formal. You know, we talk about how we write in a chart makes us look good or bad. We want to write professionally. Demonstrates is a more professional word than shows. Nothing is wrong with saying he shows great ability at this. But he demonstrates great ability with this just sounds bougier, right? Okay. Because that's what we're all looking for. And I just made up a word in class today, I think, adding the ER. Noted, observed. You don't necessarily have, these aren't for you to memorize or anything. These are just ones that I've noticed and think that are some really good ones. Mental state. Constant. You're going to talk about words, and these are words that you will use in your documentation, in your notes. This, by the way, this paper, if you are ever going to work in therapeutic rec or something where you're going to have to write progress notes, this is a good little thing to just hang on to also, because it gives you, I mean, you could refer back to this when you have to start writing in charts one day, because it has good descriptive words that will work in other fields as well, really, if it's a service field. Mental state, concentration, were they able to concentrate? Clear, comprehension, they were very alert, they were confused, they were focused. These are things that are clear, it's obvious. For those of you that are going to watch this later, I'm sorry I keep stepping out of the frame, I forget that I'm videoing today. Of course, as long as you can hear me, that's all you need. I'm sure you don't care to watch anyway. Preoccupied, hallucinations. If someone is having, because in some settings, people have hallucinations. Drowsy, distractible, delusions, disoriented. These are all very descriptive words. That's the key that we're looking for here. Thought process. Scattered, rambling, generalizing, obsessive. I've used obsessive in some notes that I've made before. You know, they can't get over something that they're just, especially, we've talked about people who are on the spectrum for autism. One of the big things with that particular group of people is they are big on a schedule and they're big on repetition. And if something throws the schedule off, they will obsess on that. Like if they have swimming set up at 1:30 on Wednesday, you better believe me, if they enjoy swimming, they'll be watching a clock starting at, gosh, who knows how early that morning. And when it starts getting to be 1:30, they will be telling their supervisor, their therapist, their teacher, whoever they're with at that point, time to go swimming, time to go swimming, time to go swimming. I mean, like totally obsess over those things. So obsessive is a good word. Affect. What is our affect? Where do we show our affect? Am I asking hard questions today, or are y'all just really tired?
Is it mood?
Huh?
Mood?
Yep. So usually that's shown on people's faces. You know, it's one of those things that's kind of all over them, like we talk about. The common word that you hear go along with affect is flat. You know, the patient had a flat affect, which means basically no matter what's going on, they just have this blank. They're not smiling, they're not upset, it's just like almost glazed. A flat affect is just totally nothing's really bothering them, nothing's really getting them excited. They're just look like zombie almost. Flat affect. They're not showing emotion. Depressed, sad, remorseful, belligerent, agitated, calm, relaxed. These are all things, again, remember though, when you're doing these descriptive words and using these description in notes, that you're trying to make sure that it actually happened, that it's, that you're not just assuming, I think they were agitated today. Your note needs to be, Tom was clearly agitated during class today. You know what I mean? Not, I feel that he seemed to be agitated. He was agitated or he was not. If you can't do that, don't put it in there. All right. Next page. When you're talking about in your documentation, your people following directions or not. Some good terms are things like follows directions, retains instructions. What do we mean by that? That just means, look, once I tell somebody how to do something one time, I don't have to keep telling them over and over. They retain the instructions. They get it. Needs clarification. They learn quickly. They follow demonstrations. They need repeated directions. Those are very clear of how, when you're trying to teach someone or lead an activity, what you're having to do with them. It's just a descriptive way to put it. Use of time. Irregular attendance. They're slow to get started. Work steadily. Work slowly. Sets goals. Productive. Skip steps. That's important. If you have someone who skips pieces of what you're trying to get done, that's something that you have to kind of work on. So you would note that they're skipping steps along the way. Okay, you guys can go through these. I'm not going to talk any longer on this page because I'm just sitting here reading words that this is honestly just a good reference for you. I'm not going to sit here. I don't want you memorizing the things that you're marking today on that. So let's move along. So let me actually, it goes back a couple pages where we talked about, there are 3 ways talked about in this paper right here that a therapeutic recreation specialist activity therapist is going to initiate services with a client. Okay? The first one is on page 158, and it's unit coverage. The first way is when the recreational therapist is responsible for seeing all the patients on a unit. That's, you work in a facility. You're responsible for a certain unit of clients. In this case, the therapist is expected to make basic formal evaluation of the patient's needs between the 1st and 7th day after admission. You need to, that's getting the process started early in the game. You also have to, in the second paragraph, the therapist will need to determine which patients will require the most immediate care. That's important, right? It's just like they have to do in the ER. Who needs, who's having a heart attack and who has a fish hook stuck in their finger? Does it suck for both of them? Absolutely. But do they have to figure out which one they need to try to work on first? Yes. Same thing with us. Now, that doesn't mean we're neglecting anyone, but it gives us a sort of hierarchy of where to start and really where to put our energies up front right off the bat. Now, these priorities, it says here, they're based on the results of an assessment combined with professional judgment. Okay? It also can be from talking to our peers, looking at literature. We've talked about how the history of our profession is important, and the history is not just, it started years ago with hot springs, and we're not talking about necessarily that history. It also, somebody else tried this in the past with someone who had a very similar situation, and it worked very well. So that is historical, even if it was, a year ago. It's in the past. We can learn from what they did and whether it worked or not, and it can give us ideas on where to go. Okay, so that's the first type of, or the first reason that a therapeutic rec person would begin working with a patient. Second manner is on page 161. And you may initiate contact with a patient through a referral, which is a formal request in writing, usually documented in a medical chart, from another person who has a legitimate interest in the treatment of the patient. A member of the treatment team, a legal guardian, insurance company, trust fund supervisor may refer a patient to the therapist. Okay? Notice who I didn't name right there when we're talking about who said you need to work with this patient. I didn't say a physician, right? That's because they fit under the next one, which is on the bottom right of the same page, and that would be prescriptions. The third way to initiate interaction with a patient is through a prescription. It's a formal order from a licensed physician. A well-written prescription is going to indicate if the therapist is to evaluate the patient and or provide specific treatment or instruction. Usually a prescription is also considered to be a referral so that both are not needed. So prescription equals referral if given by a physician. That being said, a referral is not a prescription. Most third-party payers will not pay for recreation therapy services on the strength of a referral alone. If you want to get third-party payment, then a prescription is frequently needed. That's a pretty important area to make note of. The prescription comes from, a referral can come from friends and family, You hear car companies, I just got a $100 check for getting my parents to buy a car off Carvana. That was a referral. I referred them to Carvana because I bought a vehicle from them before. That's a referral. A prescription comes from a physician, therefore it merits the insurance companies and such are gonna say, hey, this came from the big dog, this is worth paying for. Get where I'm coming from on that. Because referrals can come from a lot of different places. Okay, go to the next page, 162. Documentation related to the referral and the initial visit. It's on the right-hand side there. After receiving a referral or prescription for treatment, the therapist should acknowledge receiving the referral, prescription, and the chart. Some of this is cut off, so I apologize for that. The therapist's notes should reflect the information obtained during the referral process. The therapist's documentation for the initial visit should also reflect that some of the orders were carried out during the first visit. And right below that, I'm not going to read it out loud, but a perfect example are two notes that you could use that would be used for documentation talking about a prescription that was given. Well, I will a little bit. Order received for recreation therapy services. Chart reviewed, evaluation to follow. See how succinct, see how simple that is, yet it says everything that has happened to that point on 6/11. That's what we got. So this is where we're going. So then, after you've done some more reviewing, evaluation, assessment type stuff, on the 13th, Emily is a 2-year-old female referred to recreation therapy by Pam Ellie for evaluation and intervention. The two primary reasons for the referral were the maintenance of as normal of a developmental progression as possible through the bone marrow transplant process and to provide the patient with age-appropriate avenues to express her fear and anger related to hospitalization and illness. So I just lied to y'all. I said I'm not going to read this, and then I read it. So now you know I can be a liar, but it's usually for a good reason if I do. Good example of specific, concise, clear documentation and charting. Okay? Next page, 163. Just because you get a referral, you do not have to take it. Okay? What might be some reasons that you might not?
You can't do what the physician wants.
Yeah, that's it. It's not your area. It's not your expertise. You don't have, if they wanted, they might write a prescription for aquatic therapy and you might not have access to an aquatic facility. At that point, you would have to turn down that particular prescription, right? You can't do it. If you feel that there's some sort of conflict of interest or something like that, if it's a friend of a child of a friend or something like that, and you feel that they're just going to be too intrusive, so you would prefer another therapist work with this patient because it would be better because they wouldn't have already know the client. That would be another reason for maybe turning down a referral. Just remember that that when referred, you wouldn't want to make a habit of saying, no, I'm not going to do this one. I don't want to do this one either. Give this to so-and-so. You're not doing that, but there's situations where it's not going to be appropriate. They're not within your scope of practice. They may overextend the staff coverage. It's not considered professional to document in the patient's medical chart that there's not enough staff at the moment to provide services. Below are some examples of how to decline a referral. Those I actually am not going to read, but they give you a good example of how something like that would be written out. Let me tell you a little secret on this too. It says, they put it as this: it's not considered professional to document in the chart that there's not enough staff at the moment to do this. It's far less about it being professional and probably more about they don't want the accrediting bodies that are coming in and checking your paperwork and such to see, they couldn't do this because they didn't have enough staff to do what they were doing, to do what they were asked to do. That looks bad, y'all. So they don't want you to put that in the paperwork. At the same time, something that you do have to remember is we all know what CYA stands for, right? You have to cover your, cover yourself. So there may be times that you feel like you need to put something like that. Look, I was asked to do this. We just strictly did not have, due to this situation, we didn't have enough staff available to perform this. If you're given an excuse along with it, it looks better than just saying we were understaffed, so we didn't do the activity. I'm not telling you to lie or anything along that line. Okay, everybody heard of SOAP notes? Okay, well, you will today if you have not. What they stand for, and this is pretty important stuff, really. You'll hear of this again in your life, I can assure you, somewhere. SOAP notes, they need to be when we've been talking about, and I'm just going to read the top part under SOAP notes. Up to this point, the examples and the documentation you've been seeing, they've all been written in narrative style, kind of sentences, paragraphs, right? So when you're using a narrative style, the therapist writes his or her note in the same manner that he or she would report the information in a team meeting, just like you were talking to the rest of the group. Some facilities use a style called SOAP notes, as your progress notes and documentation. And SOAP stands for Subjective, Objective Assessment Plan. Pretty easy to remember once you think it through. So, the example on the previous page that we didn't cover, but we are going to go through this and talk about why there's subjective, objective, etc. So, if it were written in SOAP format, it would look like this. Subjective, the S. Emily cried. Her mother said she has no toys in here because I'm afraid they might have germs on them. And my other children are upset because they have not seen me for 2 days. Okay, why is that subjective? What is the definition of subjective? There's no room for question. You know what I'm saying? This is what was said. You're just documenting what you saw, what you heard, what you felt, what you touched, not what you thought about it. Emily was crying. You saw it. Her mother said this. You wrote down exactly what mom said in the note, right? That's subjective. O, objective, okay? Emily was crying, clinging to her mom and hiding her face from the therapist in an age-appropriate manner. The room had no toys in it. Mom's facial expression showed strain and a frown. It was obvious from her red eyes and the tear stains on her face that she too had been crying. Still factual, but do you see where there's a little more, you're making some assertions on your own in that one to a degree, where you're more so than the first one. A, assessment. Both Emily and Mom appeared to be upset. 2, Mom did not understand protective isolation procedures related to toys. So we're talking about the germs. Mom did not know how recreational therapy facilitates the cleaning of the toys for Emily. 3, Mom needed some help with childcare for the 2 siblings. So this is saying what was going on, straight up. This is closer to the other documentation we were doing. 4, therapist noted that Emily had stopped crying and that Mom was smiling when the therapist left. P, the plan. Therapist questioned Mom in a supportive manner to ensure that she understood the protective isolation procedure as it related to toys, which is ensuring that they're clean. Number 2, therapist gave Emily a doll with extra face masks, demonstrated to Mom how to play games with the doll and mask to help demystify the face masks. So we're into the planning thing. We're working on the problem. Therapists discuss issue of siblings with Pam Ellie, the social worker, who stopped in during the recreation therapy session. Arrangements were made to have child care for the siblings coordinated, where they wouldn't have that issue again. Recreational therapy treatment 3 times a week and 2 times a week as needed until discharge. Okay, we're back to very simple, straightforward abbreviation notes here on number 4. Recreational therapy to clean toys for Emily as needed. Okay, that's what SOAP notes are about. You may work in a place that one day that deals using SOAP notes. So now you will at least have had some sort of exposure to it before you just show up and they start talking about, well, we use SOAP notes here. Maybe you'll say, I remember that day that I was bored in class and he was saying something about soap up there. Okay, so let's talk about assessment again, that's what this whole class is about. Go to 164. A big reason for assessment is on the bottom left down here, establishing a baseline for treatment. Okay, we need to know where we are to know where we're starting from to know where we need to go, right? So we need a baseline. Because the recreational therapist is providing a therapy with a specific goal of changing a patient's abilities, they need to assess a patient's needs prior to beginning any treatment. Progress notes should indicate that some type of assessment has been initiated, so that needs to be documented in that you've done your assessment, or what assessment you're going to do and when. You're documenting that going on. Then once you've done that, you're going to have some documentation relating to the treatment plan over on the next side there. A treatment plan should be entered into the medical chart after an assessment has been administered and interpreted, and the therapist takes their own personal experiences, professional experiences from the past, and applies them to what they found out in the assessment, right? So we're getting to the treatment plan. So you've taken that, interpreted it, and the therapist has met with the rest of the team, and after the patient and their legal guardian have agreed to the treatment plan. That's when you put it in the medical chart. Once you've got because what if you write it in the medical chart and then the patient doesn't agree? And if you're doing what I always say we should do is include our patient in the planning process, then that shouldn't be an issue. But you don't want to write it in the medical chart until it's kind of finalized and everybody kind of gives it the thumbs up and the green light. Because then you're getting to do a big, long single line through a whole paragraph that you've written out. You don't want to do that. Just something to note. Let me see where I want to go next here. Let's jump ahead to 167 for the sake of time. Documentation related to ongoing service delivery. And look, I'm sorry that I'm just basically reading this stuff to you guys. I don't like to do that as a general rule, but because this is just kind of a one-time thing, it's framework for what we're doing, and it's something that you're going to take with you, I thought it would be that we could fight through it for one day. We won't do this every class, I assure you. As far as documentation related to the ongoing service delivery, documentation of services should continue throughout the entire time the therapist is working with a patient. The primary purpose is to record the progress of the patient. That's why we do it. We want to see if they're meeting objectives, which is leading to them meeting the goals that we set out, right? Those are the type things that we're going to be documenting. Progress notes. Whenever a therapist documents in the progress notes, he or she should reread their last entry. It's a good idea to do that. It's kind of like they tell us as instructors that a good way to start your class is to come in and say, in the last class we talked about this, and you kind of go back over what you did last time and then get into the new stuff. Sometimes I do that if I feel that it fits the bill. Sometimes I feel like it's kind of just going to make us be here longer, so I won't necessarily do that. But by doing so, what it says here, it's done to improve the continuity of care, quality control, and to catch loose ends that still need to be addressed. So, sometimes we forget things. We may make a note and then forget to revisit that, right? From what I saw today, I need to talk to the patient about so-and-so, and then you might not have talked to them. So that's why it's a good idea to reread the one before prior to writing your next one. Okay, 168. When you change what you're offering to your patient, to your clients, this is noting a change in normal service delivery, left side center. Whenever the frequency of recreational therapy service changes or the nature of the service changes, the therapist should note the change and the reason for the change in the progress notes. Okay, you need to document those things. You don't just, without giving an explanation for the change, again, that's another one of those things that doesn't look good. And also, if you have another team member look at the documentation, they won't be able to put the puzzle together because you haven't explained it to them. This is why we changed it. So, important to do that. Okay, something important. This is not super tied into a lot of the rest of what we've been saying. Go to the very bottom right of this same page, 168. A patient's right to refuse assessment and treatment. You run into this sometimes. You know how I've talked about sometimes we have to talk to the families? Sometimes that's because of non-compliance, because the patient just doesn't want to be there. They don't want to be assessed. They don't want to work on anything. They don't want to be where they're at. So there's something here. It talks about a patient's right to refuse assessment and treatment. Since the 1980s, the patient has increasingly been seen as a consumer of health care goods and services. Next page. In this light, the patient has the right to be non-compliant, to refuse an assessment, and to refuse treatment. The patient is also a consumer who has responsibilities. One of those responsibilities is to make a reasonable effort to comply with his or her treatment program. Because the patient's rights allow him or her to make choices, a therapist who forces activity after noting a patient's refusal or noncompliance may be seen as violating the patient's rights. Okay. A note on that. There's a difference between downright refusal and being hesitant. Okay? You have a new patient. You work at a nursing home, or you work at any sort of facility where there's multiple patients there, okay? When you first get around a bunch of new people, most people are what? Shy, right? You don't want to just jump in and go to the party because you don't really know anybody yet. You want to kind of run into them in the hallway first. You get what I'm saying on that? It's hard. So they may, if you say, hey, we're having a Thanksgiving luau tonight. I don't know. That's not important. You're having an event tonight, and we'd love for you to come. And they're like, no, I just got here. I'm settling in. Is that refusing? You got to learn how to draw the line there. Part of being effective is that realizing a lot of times our patients will be hesitant, and there's a difference between hesitant and saying, no, hell no, I'm not doing it. When they go there, you're like, okay. You're not going to force them, and that's not our role. But if someone is just hesitant, you say, oh, come on. come try it tonight. I promise you're going to have a good time. And if you don't, I'll admit that I was wrong. You'll be surprised. These are really nice people. Just come on and let's come on with me and try it. I'll come back here and we can walk in there together. I'll introduce you to everyone. You see how you're being supportive. You are not forcing, but you are kind of being motivating. That's a good way. You got to be a motivator sometimes, and you got to do it in a certain way, and that depends on the patient. Substance abuse type settings, you have people who are very defiant because they got put there. They don't want to do things. Some of those people, you have to be tough love kind of situation where you're like, no, look, you need to come on with me. I know you don't feel like doing this, but come on. I'm going to help you get better. That's a lot different than saying, come on, there's a lot of nice people down here. You're going to have a great time. You're not saying that. You're saying, look, I'm here to help you. And if you'll come with me, then at that point, if they're like, nope, not doing it, at a certain point, you have to kind of wash your hands and walk away and realize that we don't have the ability to force them to do things that they don't want to do. Just wanting to share that with you guys. Okay? Documenting on sensitive topics. 169, right side, bottom. Actually go up one. I don't have it marked, but it's interesting and it's very fitting in today's society. And, everything's got to be politically correct now, right? It's important. People are super sensitive now. So political correctness is a big deal. A few years ago when I marked this paper, it probably wasn't as big a deal as it is now, or I would have had it marked already. The therapist should be sensitive about the way they portray patients in writing. While some of the do's and don'ts of using descriptive terminology vary depending on parts of the country, there are some basic guidelines available to the therapist. Table 8.2, enabling documentation, provides the therapist with basic rules for non-discriminatory charting. It's in here as well. It's actually the next page that you'll get to. When you're documenting sensitive topics, okay, you have to realize that sometimes we have to record sensitive information, but we need to do it in a tactful, neutral manner. Sometimes that's easier to do than others. Now, it says here, it's unlikely that any recreation therapist will be able to avoid working with patients who have been either psychologically or physically abused. Every therapist needs to be able to document on sensitive issues in a way as to have the documentation hold up in court. Now, that being said, don't let that frighten you. I've never had anything that I documented ever get pulled into a court, and I did it for a lot of years. But it's important that you do your documentation properly. Some of the basic guidelines to follow in these situations, again, write down observable facts only. Be very concrete in describing what was observed, very specific and concrete. Make sure that the events written down are recorded in the exact order that they happened. Important. Avoid all mention of feelings. It's acceptable to report a quote from the patient as to how he or she felt. When he did that, I felt very dirty. Not the patient felt dirty when he touched her in that manner. You see the difference in those? You're putting an actual quote. So just something to think about. Okay. 8.2, we're almost done. We're fixing to quit. But it talks about this enabling documentation. And in SRA 262, you've all been through that class, right? Has anybody not been in it? We talk about person first terminology. Remember that at all? And how we talk about the person, not what they have going on. That's a lot of what this page is about. Think about the difference in how, in your documentation, and how it looks if you say a woman with a burn versus the burned woman. Okay, both are accurate, right? Woman with a burn is a yes. Burned woman is a no. Child with learning disabilities. Learning disabled child. Y'all hear the difference and see how one is much better? Man with dementia. Demented individual. That sounds like he's fixing to kill somebody. Demented. I think of like a clown with an axe when I hear that. Look down here below. Phrases to avoid and alternatives. This is great. Like I'm telling y'all, this is a good chapter in this book. That we don't have to memorize a lot of stuff, but you look at it and can refer to it. Like you don't want to say afflicted with. They have MS. They're not afflicted with MS. You see how much worse it sounds? Crippled is not a good word. You don't want to be patronizing to the people. So you do something it says on the bottom left down here to think about. I'm sitting here talking about being politically correct and being enabling in our documentation, right? That's important. You want to use the right things that portray things in a positive manner, okay? At the same time, you have to remember that you do have to outline disabilities and you have to be realistic. Don't portray the person as a superhuman while you're trying to be enabling. You know what I mean? You can go over the top and trying to be PC and not give the true story. Don't paint them as a totally helpless individual, which is kind of just the opposite. You want to, and it comes through time, practice, seeing other notes, things like that. Let's do this top right one and we'll stop here for today. There's a few, maybe a tad bit more I want to cover on this in the next class, and we will talk about, what did it say on the syllabus? We'll cover another topic and the rest of this next class. But the last thing I want to read, just as an example of how we do enabling documentation. What sounds good, what does not. Let's read the no first. This is how we should not do it. The head injured 34-year-old male needs one-on-one supervision in the community due to poor judgment. He does a great job getting around, having worked hard to overcome a right-sided weakness. Okay? It says below that, don't depersonalize your patients when including them as part of a disability group. A better way to write that same thing would be above, yes, here. 34-year-old male with cognitive disabilities in the areas of problem solving, judgment concerning safety, and pathfinding due to a head injury as a result of a motor vehicle accident. No apparent physical disabilities noted except for slight weakness in the RLE, right lower extremity. Very professional, very straightforward. You're not calling them head injured. You're not saying that they have poor judgment. You see what I'm saying? You say they have difficulties with this, not they make the wrong choices. Sorry if today was kind of dry. I do think that this is important information. Like I say, we'll build on it more as we go through the semester and do some actual assessment type things. These are the type thoughts I want you to have. We'll finish up the last little bit on this and go into, I don't remember what was on the syllabus and I can't find it right now, but we'll cover one other topic. If you don't have your book, start pushing on getting them, because here in another week or so we're going to start getting into them. I think it's next Thursday actually. We're going to cover pages 1 through 32 in the case study book. So try to have that at the very least where we can go over that material and talk about how we're going to talk about those specific case studies as we go along. Have a great day. Stay warm. Have a good weekend. See you guys Tuesday. Adios.